Good afternoon. This is Erin with the Department of Medicaid. It is not quite 2 o'clock and we're still clearing out the waiting room, so we'll give it just a few moments before we get started.
Mhm.
Good afternoon. It is now 2 o'clock and it looks like our waiting room is clear. Keith, I currently have yourself, Jacob, Josh, Linda, and Steve logged in. I know Dana's not going to be here, and Troy, if I missed you, just let me know.
All right, can you hear me okay?
I can.
All right, I was having trouble getting off mute there. All right, sounds like we have quorum. Just a reminder, anytime that we do any kind of voting, we do need for all of the TAC members to go on screen so that we can do the vote and show that we've got everybody available. If you are in a car driving or something, just speak up and let us know, because obviously I don't want you to have to try to configure your phone while going down the road. That's just not safe. So, all right, go ahead and start with, thank you for everybody for jumping on the call. We have quorum based off of what Aaron has told us so far. At this point, I'll open it up to the TAC members to get approval for the minutes from the January 27th meeting.
Motion to accept the minutes.
All right, we have a motion from Jacob. Do we have a second?
Second.
All right, got a second from Steve Eubanks. We got a motion and a second. Any discussion about the minutes? Very good. Hearing no discussion, call for the vote. All those in favor of approving signify by saying aye.
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 Opposed? Abstentions? Very good. Motion passes. Thank you all. All right, jumping into old business. One of the items that has been brought to our attention is we have some issues with the PCS forms that we had worked on last year, getting approved to be able to be used in lieu of pre-authorizations for EMS reimbursement purposes. We have heard that there have been claims from WellCare and United that have been denied because EMS providers did not file pre-authorization. So, because of the process we went through, and we all believed that the PCS form was going to be the authorizing document. I would like to get input from everyone on what's going on. Why is the PCS form now not being accepted when we had all voted and approved that it would? So I'll open it up for anybody that can provide information on that for us.
Hey, Keith, this is Stuart Owen with WellCare. Good afternoon to you.
Hi, Stuart.
Yeah, we've checked internally. We are doing that for if they're an out-of-network provider, because we require any provider that's out of network, we require a PA, because one of the things we do when that happens, we look to see, is there an in-network provider, it's an option for the member. And, we also want to track, like, what particular services are we getting out of network. So and then I know otherwise there's been a few denials where the team actually showed that the form was not legible. But as far as PA, and I mean, we've had multiple meetings internally. It's just when they're out of network, they're not a participating provider in our network. And that's a general rule for all the whole spectrum of providers. If they're out
Okay.
of network, we require PA.
All right. Steve, Jacob, or Joshua, if you all can verify for me. I know as somebody with Baptist Health, we're in network because we have to be because we're a hospital-based service. But with you all being community-based, are you all in network with any insurance providers, or are you all considered out of network for everybody? And if so, how is this affecting you all?
Keith, on the air side, it's kind of hit or miss. We have certain contracts with the NSA rulings and stuff. They have moved towards more out of network and not having the contracts just because it was kind of muddying the waters on the mediations with the air and patient and air and insurance carrier kind of deal. But for the most part, we're in network still with, the Humana providers, the Anthem providers currently until those contracts are basically terminated or until they end. So, but currently, usually ours probably majority are still in network.
Okay, very good. We got a hand up by Don Jones. Yes, sir. Go ahead.
Hey, yeah, hi. Sorry, I took a minute to get off mute. Hi, my name is Don Jones. I'm the Director of Operations here for the UHC Kentucky Health Plan. This is my first time attending this call. I was asked to come here to speak to this. I can say for UHC, I ran a report. We did not have any claims that I saw being denied for authorization. I did see a number of claims being denied for missing the form altogether, or for the form being incomplete or not correctly filled out. But we do not have any denials for authorization for this service.
Keith, there's also a comment in the chat from, I think it says Shelly B. WellCare has been denying if there's incompleted boxes in section 1, Medicare Part A or hospice. Also, if the header is cut off the top of the form.
Yeah, I mean, I know if it's incomplete, that's not a PA scenario, but that's where the form was attached with the claim. That is a requirement that the form has to be completed, like fully completed.
Okay, and will something as simple, I hate to minimize it, but something like the header being cut off, will that trigger a non-payment as well?
I mean, if there's, I would think as long as there's the member information, provider information, I don't think the header would matter. I mean, I can check with the team, but I mean, I know they look at are the fields actually completed. So, if the fields are completed and the headers cut off, that should not, result in a
Speaking for
denial.
sorry, Stuart, I didn't mean to interrupt. I
No, you're
actually
fine.
wanted to say, speaking for UHC, I would expect exactly the same. As long as the sections are filled out completely and correctly, I wouldn't expect any header at the top of the document missing to be an issue.
All right, thank you.
But I'm happy to look at examples if needed.
Okay, and that's where I was getting ready to go to. Since Dana's not on, I want to check with Linda. Linda's a partner of ours from 911 Billing and Consulting. Linda, on your all's end, from what you've seen, have you all seen any of these claims getting kicked back or sent back because of the errors or omissions that have been brought up today? And then second, how many of your clients, ballpark, you don't have to give a specific figure, obviously, but just as a ballpark, do you all have a lot of EMS services that are in network, or are the majority of EMS providers considered out of network with insurance providers?
I believe the majority of our providers are in network, and it's not been an issue for them. Of course, if something's left off, we expect that, but we try to minimize that by reviewing the documents before they're sent in. But the majority of our clients are participating providers. if something's left off, we understand that's a requirement, and we're quite willing to go back and make sure it gets done correctly.
Okay, very good. Thank you, Linda. And then both Don and Stuart, if the people are non-participating and a PA has to be done, is this the same PA form that had to be submitted prior to us accepting the PCS form in its entirety?
Speaking for UHC, all we need is the PCS form. In network, out of network. Speaking for UHC, all we need is the PCS form.
Okay,
Yeah, I mean, as far as what PA form, I don't know for certain. I would think it would be the same one, but I don't know for certain.
okay. If you wouldn't mind, obviously not for today's purposes, but if you wouldn't mind, Stuart, if you could just check to be sure, because if at the next board meeting, next KBEMS meeting, I'd like to do a briefing to let everybody know what we've talked about in the TAC meetings. And in case somebody does ask which PA form do they need to use, I'd like to be sure that I can give them the right information.
Yeah, I'll email Aaron and I presume your email's on the invite, I guess.
Yes, yes.
Okay, all right. Yeah, I'll email you and Aaron.
Okay. Very good. Thank you.
Sure.
All right. Is there any other questions regarding this topic from the TAC members?
Do we have a contact for the different managed cares of who we need to contact if we're running into this issue? We've had Passport and WellCare both denials for pre-auth.
I'll put in the chat our provider relations representative for WellCare. I know she's not on the call today, but we have one for transportation. I'll put her name and email in the chat if that's okay.
Yeah. Aaron, do you by chance have that information that Steve was asking about?
What I could suggest is I can reach out, and I'll reach out to all the MCOs. You should have a provider rep. If you're not able to work through your provider rep, we do have an MCO provider inquiry path as well. But I will reach out and see if I can work on getting the contacts from all the MCOs for the EMS providers.
Okay. Stephen, does that work for you?
Yeah, that'll work. And then if we can follow up at the KBEMS meeting with the information for prior authorization, because what we're running into is the people we're talking to at both Passport and WellCare is they are not aware that prior authorization had gone away at all. So
Wow. Yeah, that's significant. Steve, if you don't mind me asking, do y'all use a billing service? Do y'all bill in-house?
kind of a combination. We do coding, and then AMB does the processing for us.
Okay, very good. All right. Any other questions about the PCS pre-auths or pre-auths? And Stuart just put a link in for WellCare as far as provider relations. All right, so let's go ahead and jump down to item number 5, which is new business. I will tell you all that there has been a flurry of activity that has gone on within the EMS community regarding Medicaid bills that were, whether they were submitted, whether they were altered at the last minute to get through the legislature. One of those issues we got taken care of late last week. I don't think we need to necessarily bring up unless one of the TAC members wants to. However, I think the one item that I would like to ask our DMS partners to discuss during the last MAC meeting, Aaron was able to distribute a report, a very troubling report showing that if the federal government cuts the Medicaid funding on their behalf to the levels that has been suggested, how it's going to adversely affect the different programs within the state. One of the items I did not see identified in that report was talking about the GEMT program or the latest APAP program that was recently approved for EMS to be able to boost billing. And I would like to ask our DMS folks, Steve, if you're willing or able to comment, Steve Bechtel, if you don't mind, if you could talk about this maybe a little bit about how this could potentially, are these programs part of the programs that could get axed as a result? Basically, any information you have, because right now I got to tell you, depending on what organization meeting you're in, you're going to hear different answers about what is considered on the chopping block, what's not, what's safe, the whole 9 yards. So whatever you could provide would be outstanding.
Okay, so just let me, Steve Bechtel, Chief Financial Officer here in the Department of Medicaid Services. I want to make sure that we have the right terminology here when you say GMT program and the APAP program. The APAP program is what we've been paying in what we call the APAP program is what we've been paying in that supplemental payment that you all pay a provider tax on. It's the Ambulance Provider Assessment Program, and that's what APAP stands for. That at right now is at a 5.5% tax rate, if you recall. Right now, our safe harbor, the federal safe harbor, is a maximum of 6%. If you hear that they lower that safe harbor to 5% or anything lower than 5.5%, it will impact this program because I can only draw down the federal match up to the level that they're allowing me to do in provider tax. So if they lowered my tax limit to 5, it will lower that a little bit. So I just want to be up front with you on that. The other program from House Bill 152 that just got passed, we're in the process of working on that. That's going to be called ASPP. It's ambulance service payment, ambulance supplemental payment program, I think is what we called it, ASPP. But that's in House Bill 152, both of which we hope to have the calendar year 26 preprints submitted by probably August of this year, if not earlier. So that will keep both of those programs moving. Well, for the new one, it'll get it kickstarted, but the one that you all are used to receiving that we've been working in processing over the last few years, that one will just keep it going. We do have approval for it for calendar year 25, so 26 would be the next one that we would submit. Pertaining to other cuts that you're talking about there, Keith, is it's really an unknown right now. Because we have no idea what the federal government's going to do. They gave us proposals, or they said, here's things that we're looking at. The provider tax that I mentioned was one. Another is a decreasing of the FMAP for our expansion population. And our FMAP is the amount, what percentage of federal funds comes to Medicaid or comes to the state for expansion. Currently, we get 90% federal funds, and 10% of that is put up by the state. If they lower that to our current rate, which is 71%, that's a dramatic drop, and it'd be very expensive to the state. It'll cost the state over another $1 billion, if not 1.4 billion, in additional state revenues. So that in itself would either require us to either, and I don't want to say either way, but it would require us to either eliminate the expansion population or and not serve or not cover them anymore, which would be a direct impact to providers as well. Or it would be a sense of where we're going to have to make drastic cuts in order to keep funding that program, or we get general funds. But the general funds is, I'll just be honest with you and transparent. You know me, Keith. I'm just as I'm what you see is what you get, right? But when it comes to general funds in the state, as you all know, and I'm appreciative of it, don't get me wrong, I want more money in my pocket, but the state legislators are reducing every year reducing the state income tax for everyone. And that by doing that, it's eliminating revenues that the state has to fund these types of programs. So I just don't see that that's going to be an option. So it leads back to either Do we cover expansion, or do we drop them, or do we cut services or cut reimbursement elsewhere? As far as we're not, we haven't gone very far on what that's going to look like. But I just wanted to let you know, and just be as honest as I can with you all. It's very unknown at this time if that's going to impact. Now, the other thing that the federal government's looking at is a per capita cap. You probably heard that as well floating around. Per capita cap just gives us a certain dollar amount per member that we are allowed to do all of these services, but we have to fund it underneath that cap. And it's based on your per capita income, which in Kentucky, our per capita income is probably one of the worst in the nation. And
Right.
that's why we get a higher FMAP than we had the 5th highest FMAP, which means that we have the 5th lowest per capita income. So that being said, I'm not sure what's all entailed in a per capita cap, what they're proposing as a inflationary adjustment. I don't know if they're looking at CPI, CPIM, CPIU, what they're looking at on that inflationary piece. And I'm also not sure of what their base period that they're looking at. And the reason why that's big is, as you all know, during the pandemic, we were not allowed to eliminate anyone, or not, I wouldn't say eliminate, maybe that's a bad term, but terminate coverage for someone because they made us maintain a maintenance of effort, which means the only times that we could have dropped anyone from a Medicaid enrollment would be if they passed away, if they moved out of the state, or if they asked to be dropped from the program. That's the only 3 things that we could have dropped during the pandemic. And if you remember, that was 2020 to 2023. Then in 2024, we started doing redeterminations across the state, which drastically showed our decrease in enrollment. But if you use that as our base, or you use those other 3 years as your base, it's gonna muddy the water when you look at it from a data standpoint. You could either overfund or underfund the program based on a per capita cap. So that hasn't been asked. I've met with the Congressional Budget Office, and they didn't think about that, and so I'm not sure that that's on the table any longer. If they said if it is, it will most likely be just the expansion population that they look at. So.
Just out of curiosity, I've heard that this upcoming legislative session that they are going to be working on the MOAB. Is there any thoughts one way or the other of the direction that the legislators are wanting to go in? That's part of one part of the question. The next is, my understanding is there was a report that was done by Ms. Bates for the legislators during this last session. I'm just curious, is that report available to where we could see what was mentioned in there, to see if EMS was even discussed in the report? And where I'm going with both of these is the reimbursement rate for the non-emergency side is so low that I've had at least one provider say that if we can't see an increase, they're going to bow out completely of doing the transports altogether, because they simply cannot afford the difference in what their unit of service cost is versus what we're able to reimburse. And I understand where they're coming from when you sit down and look at the actual numbers that are being generated. And I think it would, in any kind of shot of optimism that we could give our EMS providers, that it's what we are doing is being looked at, because it was nice that House Bill 152 recognized the public services, but for those of us that operate not-for-profits, or for those that do operate for-profits, we're out in the wind. We're not qualified for any of that, so we're still at the low end of that reimbursement rate. So I'd like to be able to give some kind of optimistic news to EMS providers that it's.
Let me just answer that last question, or kind of address that last part. Is the reason why House Bill 152 got passed is because no state funds are necessary, because those who are qualified in the program will be paying the state match through their localities. The government agencies around them will be paying the state match through what they call an intergovernmental transfer, IGT. And per federal law, only an IGT can only be transferred between agency or governmental agencies or governmental owned agencies. So those of you who are not part of that program, we can only do the tax part, right? And unless general funds is provided.
Right.
But the legislators didn't want to provide any more state funds for the fact that I told y'all that they're trying to look at lowering the state income tax. So the maximum we can go up to at this time is 6%. You're at 5.5%, and we kind of don't want to go right at 6% because you want to give yourself some margin of error, right?
Quick start.
Right. So that's where the 5.5. So I just wanted to address that. I understand what you're saying, that some of you got left out of that, but the reasoning for that is because of the funding mechanism on the state share. As far as I don't know what report you're referring to. You're saying that the cabinet gave a report to?
No, there was a report that the legislators asked, I believe her name was Stephanie Bates, to complete that was on the status of Medicaid. And I believe that was supposed to have been compiled during the month of January and given to legislators when they came back from their break in February to discuss the different areas of Medicaid. I did have an opportunity to share a little bit of time with her to talk about EMS in general, and both myself and several of us that did have the opportunity to speak with her were curious if that report was considered a public report, if it said anything at all about EMS reimbursement or the status of our reimbursement. So basically, we would just like to see if there was some information, positive or negative, that could be shared with us as to what legislators were told, because it would certainly help us as we look at coming up with a legislative plan for this next year of basically what we would like to come together as an industry to be able to speak with our legislators so that they fully understand the payment or reimbursement status that we currently have within EMS.
Yeah, frankly, the answer to that is I'm not aware. I haven't seen a report. I haven't seen anything that maybe they've produced. I too would like to see a copy of that report. But I know that we have provided mounds and mounds and mounds of data to that area so that they can do that analysis that you're talking about and produce that report, but I have yet to see any results from anything. And I believe what they were supposed to do is try to figure out, we have $25 million given allotted to us in the 26 budget, and they were going to do this report and then recommend to us or tell us on what facilities or what provider types and what rates need to be increased based off that analysis or that report that they did. But I have yet to see any of that, Keith. I don't. You may want to reach back out to Ms. Bates and see if she can provide you that as to if it's a public facing report. I would think it would be, but I can't address that either.
Sure.
That would have to be a question you'd have to ask her.
Okay, very good. Well, I'll draw back on that and see what I come up with.
Yep.
All right. Thanks, Steve. I appreciate it.
All right.
All right. Is there any other questions from TAC members regarding the supplemental payment programs that are existing for Medicaid reimbursement? All right, hearing none, we'll drop down to general discussion. Is there any items that any of the TAC members would like to bring up under general discussion? All right, once again, hearing nothing, we'll go down to recommendations. It doesn't sound like we would have any recommendations to be able to present to the MAC when the next meeting occurs. As jumping down to the MAC meeting representation, we'll offer this up for all of the TAC membership. If anybody wants to sit in on these MAC meetings, you're more than welcome to do so. Just be forewarned, they are typically very long meetings. They go anywhere from 9 a.m. Or 9:30, sometimes to noon. Sometimes it's 10 to noon, but it can be a long meeting. And we do have the opportunity to present from an EMS perspective what we've talked about so that they are aware from the healthcare continuum in Kentucky. They know what's going on and what we're dealing with. So if any of the TAC members would like to sit in on those meetings, just let me or Aaron or Kelly know, and we can make sure that you get the links to the MAC meeting invites so you can sign in and participate as well. All right. Only other thing I got is our next meeting is scheduled for July 28th of this year from 2 to 4 p.m. Is there any other comments, questions, or otherwise from TAC members or anybody that is on this phone call? All right, very good. Call for adjournment. Do we have a motion to adjourn?
Don't make a motion, Keith.
Thank you. Got a motion by Josh to adjourn. We have a
I'll
second.
second it. This is Linda.
Okay, got a second from Linda. All right. All those in favor of adjournment, please signify by saying aye.
Aye.
Opposed? Abstentions? Very good. We are adjourned until July 28th. Thank you all very much. I appreciate your time today.
Have a good
Everybody
month.
have a great day. Oh,
You
sorry,
too.
Stuart.